रुचिर बंद कर
Who's good at taking picture?
Okay, I'll try if you're asking me this question. Deepakshi, you can turn on your video. Beta.
Yes, ma'am.
Ruchir is taking.
Ruchir, just have a picture of all.
Over.
We can't hear you.
Ruchir, you're
Ruchir, done.
You're muted, Ruchir.
Shall we start?
Ruchir, shall we start? He has to give us a clue, right?
Ruchir.
We can't hear you. You are mute.
He's muted. He's muted.
Shall we start?
Mr. Ruchir. I will call him.
Bhakti, Bhakti hai ki nahi?
Sorry. We are started. Actually, we are live now.
Okay. So, good evening, everyone. And here we welcome you all in the August this PG education program which is going on. And this is the 12th in row. And today we are here to talk about the vicious cycle of gestational diabetes mellitus, as we all are aware that it affects through generations and we need to catch it early. So now, without wasting any time, I will request Sushma ma'am to please give a welcome speech.
Okay. A very good evening to all, respected seniors, friends, and all my budding gynec PG students. It really gives me a sweet feeling today to welcome you all for today's 12th webinar of our PG Star Series by Nagpur OBGYN Society in association with NKP Salve Medical Sciences and Research Center and Lata Mangeshkar Hospital, Nagpur. Thanks, Dr. Anuja Bhalerao. You know, we were so busy in between the festivals, we and our patients in Ganpati festivals and Rakhi, and with lots of sweets to eat and very much going ahead also again, so many festivals. But why I'm discussing this? Because we know that in India, the incidence of GDM is increasing. It's very alarming, around I think 10 to 14%. Also, PCOS increasing, obesity is increasing. So we need to discuss this issue. So you know what happened? There is a one beautiful story. One patient, she Googled and she learned that the Dr. Deepakshi Gupta is now going to discuss about the GDM. So she went to her. So she started discussing with the Dr. Deepakshi. So Dr. Deepakshi advised the patient to avoid sweets. The patient said, she doesn't like sweets. So again Deepakshi said, but you are overweight. Your weight is increasing. She said, I am already on diet. But anyhow, Deepakshi has to manage this. So she consulted the great academics, Dr. Poonam Verma and Dr. Anagha Gadikar. And so we all be having the key practical points of GDM from these brilliant faculties. Welcome Dr. Poonam Verma and Dr. Anagha Gadikar. But this patient now consulted online to another wonderful faculty, Dr. Charmila Ayavu. Dr. Charmila again explained all and suggested avoid fast food, pastries and stuff. She said she loves green vegetable and stuff. But Dr. Charmila is Charmila, you know. She took the situation under her control and has given advice her words of wisdom, which are very important for all of us also. So welcome Dr. Charmila. She is going to talk on management of GDM. Now our patient again consulted to our respected faculties, Dr. Fidvi sir, Dr. Nikita Vijay, and she said, what Dr. Fidvi said, beta thoda exercise karno na, or overeating mat karo, outside food mat khao. She said, I work a lot in my house and rarely go for parties. But sir to sir hai, he again gives straight looks and smile affectionately and plan her scheduled treatment. So welcome Dr. Fidvi sir, Dr. Nikita Vijay, and again all have gathered here from different prestigious colleges to give our PGs a pulse of wisdom. Dr. Prachi Dikshit, a great academician, We know her very well, and she's holding this reins of this wonderful discussion. And our Wisdom Academy, Dr. Anuja Bhalera, Dr. Bhakti Gujar, Dr. Prachi Dikshit, wonderfully crafted this program. Dr. Prakati Kherkar was my NOGS secretary, always there to play any role. So let's eat sweet, but not our patients should not eat our sweets. Just enjoy this discussion of GDM. Thank you.
Thank you so much, ma'am. Always the journey begins so beautifully in such a narration that all are, ears on. Pragati ma'am, yeah, I would request, sweet to hear. So Pragati ma'am, I'll request you because everybody leaves, so I think you'd like to give a vote of thanks right now.
So, good evening to all. This is really a matter of great pride that NOGS is trying to connect with each and every PGs throughout the country and throughout the globe. And we are so overwhelmed with the response. So my duty is unfulfilled if I don't thank all. So all of our respected dignitaries today present here and all the delegates there. We are grateful to first of all, I'm grateful to Lata Mangeshkar Hospital, NKP SIMS, who are coordinating with us to organize this 12 web series of PG Star. Definitely, it's going to be all sweet talks out of it, how to get healthy. Thank you, Dr. Poonam Verma, for accepting to be examiner. Thank you, Dr. Angha Gadikar, for accepting to be the examiner. My dear friend, Charmila Ayuvo, you have come right from South, bringing such a sweet memories, and you're going to spread the wisdom about gestational diabetes. Thank you so much to be here. Chairpersons consented to chair the session, Dr. Nikita Vijay and Dr. Vidvi sir. Thank you, sir. Our conveners, Dr. Anuja Bhalera, she's always the pillar of support behind all the PGs and training them on all good aspects of best practices. Dr. Bhakti Gujar and Dr. Prachi Dikshit are constantly working since last 6 months to make this PG Star a big success, and they are getting through it. Today's presenter is Dipakshi, whom we are going to listen shortly. And Dr. Prachi, you are even conducting this program. Thank you so much. And last but not the least, Core Connect people, Ruchir, thank you for all the academic help and all the things which you are doing for us. Thank you so much. Yes.
Thank you so much, ma'am. Now, Dipakshi, can you please make your presentation full screen?
Yes, ma'am.
Yeah. Your voice is breaking. If we can have
your voice.
Can we have it full screen?
Dipakshi?
Yes, ma'am.
Yes. Just
Please make it full screen.
Ma'am, actually, I am sharing it in full screen.
Yes, now it is full screen.
Yes, we can see.
Move on to another slide. Move on to another slide. There's a lag in time, I guess. Timeline.
Your network
Dipakshi, can
is
you
okay?
hear?
Network
Actually,
is okay,
we are both at
Hello.
different network. Dipakshi, can you hear us?
Yes, ma'am.
So
Please
you can
keep on changing the slides. Yes.
Yes.
Can I have the CV slides of examiners?
Yes, ma'am.
Okay.
Ma'am,
Dipakshi, your voice, your net is okay? Internet? Yes.
Okay. There is a slow connection, Dipakshi. Okay, anyways. So we move on to the first session of today. That is the case presentation on gestational diabetes mellitus. And I'm very thankful to Poonam ma'am, who has given time out of her busy schedule for this session. And I'm sure we are going to learn a lot from it. So everybody be attentive. Ma'am is director, professor, and unit head of MGIMS Sevagram, which is itself a very reputed institute which practices respectful maternity maternal health in its true words, and it's a hospital which is the department is developed under her vision and is a view to watch. So we learn so much from every session which she takes about the respectful maternity care, and she has so much in her CV. She's advanced. She's received advanced training in SHRH from Uppsala University, Sweden, and from Chipmer, and clinical training for EMOC CMC Vellore. She is core committee member of PPH working group and has so many of presentations to her credits. So I welcome you, ma'am, for the session. Our next speaker is Dr. Anagha.
To go back, I think she has to go back.
Dipakshi, are you in the network?
You can mail your PPT.
Okay, so our second examiner is Dr. Anagha Amod Gadikar, madam. Again, a passionate academician who is always interested in teaching, who very willingly undertook this responsibility of conducting today's session. She is a UG and PG from Grants Medical College and past secretary and vice president of Latur OBGY Society. Currently, she is working as associate professor and unit head in BJ Medical College, Pune. So I hand it over to you, Dipakshi. Please start your presentation.
A very good evening to everyone. Today, I, Dr. Dipakshi Gupta, I'm presenting my case presentation on gestational diabetes. My patient, Mrs. ABC, aged 29 years, Hindu by religion, Teli by caste, resident of plot number 14, Hingna Road, Sukali, Umri, Nagpur, educated till 10th standard, is a homemaker, belonging to the lower middle class by modified Goswami scale. He was an unbooked case presented to the antenatal OPD with history of amenorrhea since 8 months for routine ANC checkup, and on investigations, her PGPS by the DIPSI method was found to be 180 mg per deciliter. She had no other presenting complaints and she was perceiving fetal movements well. History of present pregnancy. First trimester, it was a spontaneous conception. Pregnancy was detected by the urine pregnancy test at a private clinic after 20 days of a missed period. There was no history of burning micturition, fever with rash, excessive vomiting, spotting or bleeding per vaginum, pain in abdomen, or exposure to any radiation. Folic acid supplementation was taken. First trimester scan was done at 13 weeks and it was reported to be normal. She had 2 visits in the first trimester at a private clinic. Second trimester, quickening was felt at 5th month and she continued to perceive fetal movements well. There was no history of excessive weight gain, frequency of micturition, increased thirst, fetal edema, increased appetite, burning micturition, or pain in abdomen. There were no history of any symptoms of hypertensive disorders of pregnancy. Iron, folic acid, and calcium supplementations were taken. She received 2 doses of injection TT. Anomaly scan was done at 18th week of gestation, which was reported to be normal. Patient was advised to get PGPS by DIPSI method done, but patient did not get it done and she did not follow up at her private practitioner's clinic later. Third trimester history. Her first visit at LMH was at 13 weeks of gestation. At this visit, we advised her to get PGPS by the DIPSI method done, which came out to be 180 mg per deciliter. The patient was advised to get admitted and then she was admitted for sugar monitoring. She was perceiving fetal movements well. There was no history of excessive weight gain, frequency of micturition, increased thirst, increased appetite, fetal edema, burning micturition, pain in abdomen, and no history of any symptoms of hypertensive disorders of pregnancy. Iron, folic acid, and calcium supplementation was taken. Her 34th week ultrasound was reported to be normal, in which there was cephalic presentation. The placenta was anterior. Liquor was adequate for the gestational age, AFI 10 to 12 centimeters, and the estimated fetal weight was 2.04 kgs. Based on the patient 7 profile sugar monitoring for 48 hours with patient on medical nutrition therapy, she was started on injection human insulin actrapid 2 units before breakfast, 6 units before lunch, and 6 units before dinner, on which her blood sugar levels were well maintained. Obstetric history, she is a primary gravida. The duration of marriage is 1 year. This is a spontaneous conception and there was no history of use of any contraceptives. Menstrual history, she attained menarche at the age of 13 years. Her previous cycles were of 3 to 4 days and they were regular average cycles occurring every 28 to 30 days. She changed 2 pads per day and the menses were not associated with clots or dysmenorrhea. Her last menstrual period was on 17th January 2023. The expected delivery date is 24th of October 2023, and by dates she was 34 weeks and 2 days. Past history: no history of diabetes mellitus, hypertension, thyroid disorder, tuberculosis, bronchial asthma, or epilepsy. There was no history of any blood transfusion and no history of any major medical or surgical interventions. Family history: there is no history of diabetes mellitus in the first degree relatives and no history of gestational diabetes in mother or sister or other relatives. Personal history: she takes mixed diet, has normal appetite, adequate sleep, regular bowel and bladder movements, and there is no history of any substance abuse or drug allergy. Diet history: she takes 3 full meals. By her 24-hour recall method, the total calorie intake per day was found to be 3,260 calories per day, of which approximately the carbohydrates were 55%, proteins 20%, and fats 25%. On general examination, the patient was conscious, cooperative, and oriented to time, place, and person. Her height was 152 centimeters. Weight on admission was 69 kgs. According to the patient, her pre-pregnancy weight was 60 kgs. So the weight gain till today is 9 kgs. The pre-pregnancy BMI was 24 kg per meter square. Patient is afebrile. Pulse is 100 per minute. Felt on the right radial artery. Regular, good volume, no radioradial or radiofemoral delay. Blood pressure was 110 by 70 mm of Hg in the right arm in sitting position. There was no pallor, edema, cyanosis, clubbing, icterus, or lymphadenopathy. Thyroid examination was normal, and bilateral breast examinations were normal. Systemic examination: cardiovascular system. First heart sound and second heart sound were normal. There were no murmur. Respiratory system: bilateral air entry was equal and clear. No adventitious sounds were heard. Central nervous system examination was normal. On abdominal examination, on inspection, it was the abdomen was globular in shape, longitudinally distended. The corresponding quadrants moved equally with respiration. Umbilicus was placed centrally and was inverted. Linea nigra present. There were no scars, sinuses, or dilated veins. Hernial orifices were normal. On palpation, the fundal height was corresponding to 34 weeks. Symphysiofundal height was 34 centimeters. Abdominal girth 86 centimeters. Based on the Leopold's grip, it was confirmed that it was a longitudinal lie cephalic presentation with back on the left side and FHS heard on the left side in the left spino-umbilical line. The Likert on clinical examination was found to be adequate, and the approximate fetal weight was around 2.5 kgs. Uterus, when examined for 10 minutes, was found to be relaxed. On per speculum examination, the cervix and vagina was found to be healthy. Provisional diagnosis: 29 years old primary gravida with 34.2 weeks of gestation with singleton pregnancy with longitudinal lie in cephalic presentation with gestational diabetes.
So, Dr. Annika, would you start or should I start?
Yeah. What do you think there are lacunae in antenatal care in this case?
Ma'am, in the as per the guidelines by the government of India, the screening for blood sugars should be done at the first antenatal visit itself, and in this patient it was not done. And
why do you think that first trimester screening is very important? Why do you think that? Generally, the gestational diabetes comes in second trimester, But why do you think that first trimester screening is important?
First trimester screening is important because there might be a chance that the patient has diabetes pre-gestationally, which can lead to adverse fetal outcomes, like there can be congenital malformations in the fetus, and we need to counsel the patient accordingly. And that is why the first trimester screening is important. And also, if we start controlling diabetes from the first trimester, we can control the adverse effects which can come in the future, like type 2, like conversion to type 2 diabetes, and the vicious cycle of diabetes going on to the future generations can be controlled.
So that's true. Two reasons. One, you have already said that many a times, it precipitates in the first trimester. And if you do not have that baseline, it would be very difficult for you to follow the patient. Second is that type 2 diabetes, which is not detected early, is first time, many a times detected in first trimester. Dr. Aniga, please.
Any other risk factor do you think she has to have diabetes according to history and examination?
According to history, she was since the ethnic group which we all belong to is we are Asian, so we are already predisposed to having diabetes. And her pre-gestational weight was she was a little overweight, so that also predisposed her to have diabetes.
Yes, that is very important advice. What we should give to the patients who are obese, they should reduce their weight before going ahead for pregnancy, so to reduce the chances of gestational diabetes, mellitus, or any complications like PIH and other things. So pre-pregnancy weight of the patient matters the most in managing any antenatal patient, or when the patient comes to you as a pre-pregnancy counseling. So that should be your advice. Okay.
Also, her age was also more than 25 years, so it also comes as a moderate risk factor.
But as she comes under 30 years, so we wouldn't really look into that part. My next question to you is that the first part of history is demography. And in this demography, what are the features which are very, very important, or what are the components which are very important when you are dealing with a case of gestational diabetes mellitus?
Go back to your demography slide, first slide.
Yeah. So here in demography, what are the components which actually relate to your history, your patient per se? So we would like to know that from.
Ma'am,
see, you have written so many things. You have written name, age, religion, resident, education, booked, unbooked, belonging to some class. So what out of all these demographic factors, which are very important pertaining to your case?
Ma'am, since she is belonging to the lower middle class, so most of the patient is
let's ask you this way. Do you think the age is important, and which age group do you think you would have more of gestational diabetes mellitus or diabetes mellitus?
Ma'am, advanced maternal age is a risk factor for diabetes. Generally, if we go according to the 5th International Workshop Conference on Gestational Diabetes Guidelines, if the age of the patient is more than 25 years, the patient comes in the moderate risk group. And apart from that, the patient
which age group is particularly you have to screen for diabetes? Beyond which age?
Beyond what age you need?
See, you have 3 groups. One is teenage, another is reproductive age group pregnancy, and another is elderly primary gravida. So in these three age groups, which one you feel is most important?
Elderly primary gravidas.
So those
we
are the
consider
ones
as
where you
above the
screen
age
for.
of
You screen, even though we are screening 100% all the women,
universe.
but then that is one group
Yes.
which is very high risk for this. Another feature here, which is very important, and one probably you have missed, you haven't written the occupation. So occupation also is very important when you talk in terms of,
she's a homemaker, ma'am. She doesn't
so
work.
those who are working with sedentary lifestyle, they are the
Yes.
ones also said to be probably more prone for this thing. Socioeconomic status also, where a lot of consumption of food is there, especially in the upper class. There also there is a possibility. So your examiners may ask you that what are the demographic features which are very, very important pertaining to your case to begin with. So that is something which you need to look into. Yes. Next, Dr. Anika, please.
Yes, what are the recent guidelines for screening of gestational diabetes, which we are following now?
Ma'am, for screening and diagnosis purposes, in India, we are following the DIPSI guideline, which is the Diabetes in Pregnancy Study Group India guideline. It mentions that there is a single step diagnostic procedure in which, irrespective of the fasting status or the last meal status, we give 75 grams of anhydrous glucose to the patient, and after 2 hours we take her blood samples for sugar values, and if it comes out to be more than equal to 140 mg per deciliter, we can diagnose her as gestational diabetes mellitus. If we go according to the ACOG guidelines, then there are two-step approaches. The one-step approach is based on the clinical factors or the history, and we give a 50 grams of glucose challenge test to the patient, and after 1 hour we take her blood samples, and if the value is found to be if the value is found to be more than equal to 140, then we go for the second procedure, which is a 100-gram OGTT for 3 hours. And then in that, the patient has to be fasting for at least 8 to 12 hours. And then we take a fasting sample. And then after giving 100 grams of glucose, we take her sugar sample, blood samples at 1 hour, 2 hour, and 3 hour. And yes, ma'am.
No, continue.
And the values which we consider are there are two sets of rules. Either we can follow the Carpenter or the Kusten method, or we can go for the NDDG method. In the Carpenter and Kuster, the fasting the values are fasting 95, 1 hour 180, 2 hours 155, and 3 hours 140. Whereas in NDDG it is 105, and then 190, 165, and 145. So if any of the two values are raised, then we will diagnose the patient as gestational diabetes.
Yeah. So is there any international association of diabetes and pregnancy study group, which is one classification which is now accepted all over the world? So we in India, we are definitely following DIPSI, because our people will not return back after 2 hours if you take a fasting sample and so on. So we can't do two-step test. But do you think that all over the world, we are using this particular classification where you have fasting 1 hour and 2 hour and you don't go into 3 hour, which is the most accepted one? So what is that? And how do you do it?
In that, we give 75 grams of we take a fasting sample, and then we give a 75 grams anhydrous glucose to the patient, and then we take the sample at 1 hour and 2 hours, and the values which are considered here are 92 for the fasting and 1 hour may we take 180, and in 2 hour sample we take 153. And if any one of these cutoffs is met, then we will diagnose the patient as
That's very
gestational
nice. That is the one which is accepted recently globally. Okay. And one more question here, both of us would like to ask you. Let's say you gave 75 grams of glucose and she vomited.
Yeah.
So are you
ma'am,
going to continue the test? So what are the guidelines for that, vomiting and timing?
Ma'am, the guidelines say that if the patient vomits within 30 minutes of taking the glucose, then the test has to be repeated on the next day or later. But if the patient has vomited after 30 minutes, then we can continue the test.
Very good. So that is what we wanted to know. And one more thing here we would like to know, what is universal screening and what is selective screening, and which guideline mentions about the selective screening?
Ma'am, universal screening is when we screen all the patients who are coming to us for the antenatal visits. But selective screening is when we screen only the high risk groups. And if the WHO
It's nice,
Nice guidelines.
National Institute of
guidelines says,
Clinical Excellence, UK, which mentions specifically only about the screening in the high risk group. But there are some negative aspects of this nice guidelines. What are they? Why are we not accepting this guideline? Of course, one we fall in the group, ethnic group. But beyond that, are there anything else because of which we do not accept this particular guideline? It doesn't
What
talk
are the
about
pitfalls
any
of it?
past, yeah. It
What are
doesn't
the
talk about any
of
past.
nice guidelines,
Yes.
in short?
So this is about the screening, which I think everything you have covered. And we would also like to know the WHO 75-gram glucose findings and ADA and ACOG findings. If you could tell us the values, that would be also very great.
Ma'am, according to the WHO, we take the fasting samples and the 1 hour and 2 hour values. We give 75 grams of the glucose to the patient, and in WHO we say that if there is normal glucose tolerance if the fasting sample is less than 100 and the 2 hour sugar value is less than 140, and we will call it as a gestational glucose intolerance if the fasting value is 100 to 125, and
impaired glucose tolerance.
It is normal if the 2 hour value is less than 120, and if we will call it as gestational glucose intolerance. Value of if the 2 hour value is between 120 to 139, and we'll call it gestational diabetes mellitus if the value is between 140 to 199, and if it is more than 200 we will call it as diabetes.
126 and 200 are diabetic.
Any other test you would recommend for a patient in first trimester if the DIPSI comes abnormal specifically?
Ma'am, in the first trimester, the DIPSI comes abnormal. We will do the HbA1c values of the patient to check for the last 3 months control of the sugars, and also the other investigations which we would like to go for will be the fundus examination, LFT, KFT, urine routine, urine culture.
Okay. What is the significance?
Would you like to do something for assessing the fetus? So in other words, we want to know from you that if she is pre-diabetic or she is diabetes in first trimester, do you think that there are some tests you would like to do to know all about the fetus?
Ma'am, between 11 to 14 weeks, we will go for the NT&B scan. We will look for the knuckle translucency there, and if the knuckle translucency is more than 2.5, then we will go for fetal echocardiography at 23 to 24 weeks, so that we can rule out congenital heart anomalies. And also we can go for the double marker aneuploidy screening, where we can check the PAP-A values and the HCG values, which will tell us about
what is the specific abnormality, congenital abnormality, what you see in particularly diabetic group of pregnancy? You said the commonest is the cardiovascular, what you see, but the specific is something which we all talk about. What is that?
And that is the specific for diabetic patients.
Caudal regression syndrome.
Correct. Yes, very good. Yeah. There are two things more we would like to ask you. What is Pedersen's hypothesis and what is HAPO trial? These two trials, there have been very interesting trial and it has recommended something. So we would like to know from. Pedersen's hypothesis. You know, I mean, maybe we use another word for you, that why women gets macrosomic baby, and we explain it by the Pedersen's hypothesis. So could you please explain that?
What happens to the baby because of the maternal hyperglycemia, basically?
Ma'am, when there is maternal hyperglycemia, there will be it will lead to fetal hyperglycemia, which will lead to increased insulin production in the fetus. And this, because of the increased insulin, there will be growth of the baby, and there will also be deposition of fat, especially in the shoulders and the trunk, and insulin-like growth factors are also increased, which will lead to fetal macrosomia. And
so when do you say it is macrosomia? What is the American guidelines, ACOG? But for India, what do we consider as a macrosomic?
Ma'am, according to ACOG, we call it macrosomia when the fetal weight is more than 4.5 kgs. But in India, we consider it as 4 kgs. But if we go according to there is one study, which was the Balaji study, which stated 3.45 kgs as the upper limit for the Indian population.
But generally, if we go by reference book, 4 kg is accepted in Indian scenario.
Yes.
Dr. Anaga, please.
What do you think the patient presented in OPD to you at the 8th month of amenorrhea, and her TIPSI was 180? So what should be the further management for the patient? What you did for the patient?
Ma'am, we admitted the patient and we did her 7 profile starting, and we also did her fundoscopy examination, sent LFT studies, KFT studies, and urine. Hello?
In between, we are losing you, but mostly we hear you.
Yes, ma'am. So we sent her LFT, KFT, and the examinations. We did her ultrasound to look for any features of macrosomia or polyhydramnios in the patient. And since she was already 34 weeks and her blood sugar levels were found to be, the FBS levels were found to be more than 120. So we started her on insulin therapy.
Okay. One more question we have. Generally, diabetic women will have macrosomic baby if you don't really give her insulin at right time. But what are the conditions where diabetic women will have an IUGR baby?
Diabetic women will have IUGR, especially
You're going in and out.
Am I audible now?
Dipakshi, your voice is breaking in between.
Ma'am, am I audible now?
Right now you are, yes.
Yes, ma'am. So the patients who are generally pre-gestational diabetic patients who have poor diabetic control and who have vasculopathies are more likely to have FGR in their babies.
Any other reason beyond vasculopathy? Any comorbidity with GDM?
Which is very
there
common.
is a hypertensive disorder of pregnancy along with diabetes.
That is second. And any third reason? So these are the questions asked that where do you get IUGR baby? So one you said is very correctly vasculopathy. Second, you are right that it is generally hypertensive diseases of pregnancy, which is there. What is the third one? You giving insulin to the women. So what can it lead to? See, it can lead to repeated hypoglycemia. No, so if your dose is not adjusted and you're giving a dose which is slightly higher, or repeatedly the baby is going into hypoglycemia, that is also one of the reasons why you get intrauterine growth restriction. Okay, so these are the things. And then my next question to you is that why this baby gets into chronic intrauterine hypoxia? Why baby has chronic intrauterine hypoxia and that leads to sudden stillbirth? We know that suddenly anthropometric diameters increase in third trimester and that leads to death of the baby because placenta cannot supply. But is there any other reason of IUD in GDM?
Ma'am, one is hypoxia and the other is lactic acidemia, which is seen in diabetic patients. And
that is
there is
because why does that happen? Why does that lactic acid? So what is the series of reactions which happen or series of events which happen?
Fetal oxygen.
No, we can't hear you. You're going in and out, Dipakshi.
Can you hear me?
Yeah, we hear you in between, but in between your voice goes off.
Fetal hyperglycemia and hyperinsulinemia will lead to increased fetal oxygen demand, and there will be the oxygen will be binding more avidly, and there will be less release of oxygen to the fetus, and this will lead to chronic hypoxia, which can ultimately
so hyperinsulinemia leading to increased oxygen consumption and then leading to decreased arterial oxygen, which when goes to the baby leads to chronic intrauterine hypoxia, which once when again the oxygen consumption is less, then it leads to hypoxia along with lactic acidosis, and that's the reason for stillbirth. Okay. Dr. Anaga, please.
Which babies are at risk of stillbirth more? What are the babies? Microsomic, macrosomic, or any other?
Babies with if fetal growth restriction, the babies who have fetal growth restriction are at increased risk of stillbirth because.
And the bigger babies are at more risk of early neonatal complications. So metabolic complications are seen more in the macrosomic ones. And intrauterine hypoxia and the death occurring is very common with the low birth weight.
What are the other metabolic problems which you see in neonate of diabetic mothers? The first and then later. The first complication which you see, and that's why you always keep them under observation.
Ma'am, the first metabolic complication which can occur is neonatal hypoglycemia, because the glucose supply from the mother is cut off, and therefore there is hyperinsulinemia, which can ultimately lead to neonatal hypoglycemia. And apart from that, there can also be hypocalcemia, hypomagnesemia, and there will be hyperbilirubinemia because of the polycythemia, which has occurred because of the hypoxia status in the baby.
Wonderful. One more question, that the babies born to these GDM mothers, they say that there's something called intrauterine programming. And what is that programming which, precipitates the moment they go into their adulthood?
Babies.
So in other words, I'm asking complications or late complications in the baby when baby is adult also.
Ma'am, when in adulthood, there are risks of type 2 diabetes in these babies. They can have metabolic syndromes, and they can also have cognitive and neurodevelopmental abnormalities.
One more thing which can be seen in the female baby, especially.
Ma'am, they can also have gestational diabetes when
a commonest disorder which we are seeing nowadays.
Polycystic ovarian syndrome.
Yeah, usually they have hormonal imbalances, irregular menses, and they lead to obesity. They suddenly become obese at their adolescent or in a puberty age group, which is unexplained, which can't be explained. But we go as a backdated history, the mother may be having a gestational diabetes in her pregnancy at her time. So that female is at risk of polycystic ovarian disease syndrome as per se. Okay.
Yes.
What is HAPO trial, Dipakshi?
HAPO trial is
hyperglycemia and pregnancy outcome study. So what was that and what did it conclude? So it included more than 25,000 pregnant women of 9 countries, and they monitored them from 24 to 32 weeks. And they realized that there's a strong association between maternal glucose level, which are little below before you diagnose them as diabetes, and the adverse outcomes are seen. So it's not necessary that only 140 and above will affect badly. Even if she is between 130 to 140, she needs to be, screened or, be tested every trimester. So wherever you get these levels, don't leave them alone, thinking that once it will be 140 and more, then only I will see. So this HAPO trial has given us a lot of information that even if it is little low sugar than our cutoffs, please screen them regularly so that you know what their levels are they increasing or not, because they saw a lot of worst outcomes of pregnancy, even if the levels were not exactly 140 or above. So that was the HAPO trial. Please read it. It's a very interesting trial which has been given.
Yes, ma'am.
All right. Aniga, should we ask something more or should we directly come to the management part now?
Yeah, it will be management.
Please begin with that. Let's start with MNT. Yeah. Dr. Anka, you can begin with MNT. Let's
So
ask.
what will be the dietetic? You have given the dietetic advice to the patient. So what was your dietetic advice to the patient with her DIPSI found 180?
Based on her 24-hour recall of the diet, we found that she was consuming more of carbohydrates and less of proteins. So we advised her that she has to keep her carbohydrate, and her BMI was found to be 24 kg per meter square, and she had a sedentary lifestyle. So based on the patient's individualizations, we asked her to take more of protein. So she was advised to take at least 3 portions of protein in a day. We told her to have 3 major meals and 3 minor meals at regular intervals. And we asked her to take more of fiber-rich diet and complex carbohydrates like oats, ragi, jawar, and bajra. And we counseled her that she should not be having simple carbohydrates, she was asked not to eat biscuits and maida rich foods. And for proteins, we advised her to take more of egg whites and pulses and milk and dairy products, but we asked her to limit her fat because she was taking more of saturated fat like ghee and butter. So we asked her to avoid that also. And we told her that the saturated fat should be less than 10%. So accordingly, we made a diet chart for her.
So remember that this gestational diabetes mellitus in pregnancy is the best approach to treat this is multidisciplinary. Let's not become physicians and let's not become dietitians. Let us remain obstetricians. So it's very important that we send them to the dietitian who's actually doing this particular job. And you will find that they will say that for normal weight, we shouldn't really be giving them more than 30 kilocalories per kg per day. Overweight 24 kilocalories per kg per day, and obese 12 kilocalories per kg per day. And the calorie distribution should be in 3 meals. Breakfast 25%, lunch 30%, dinner 30%, and then 3 snacks should be added, which should be small and frequent. So total 6 courses would be the best way of managing these women. And then, as you said, that carbohydrate is 40 to 50%, protein 20 to 25%, and fat 30 to 40%. So remember here, fat is slightly more than protein. If you look into your reference books, that's the way it is. And very rightly said by you, complex carbohydrates, less saturated fat, fibers, minerals, and vitamin supplementation. This is what we really look for when we talk in terms of medical nutrition therapy. And always remember, whenever we get by DIPSI more than 140 levels, if you go into the White's classification, you have A1 and A2. So your first management is always by medical nutritional therapy, and then you again repeat, and then only you think of giving insulin, because many, many women, they get treated if you really correct their diet.
Yes.
Yes.
Yes, Anika, please go ahead for exercise, and then we go for the...
Yeah. After MNT, what else you will advise to the patient? A light amount of exercise?
Yes, ma'am. At least 30 minutes of exercise per day is advised to the patient. This will especially lead to decrease in the postprandial blood sugars. And so if the patient is not managed on MNT and physical exercise, after 2 weeks, we will repeat the blood sugar. And then if it is still raised, then only
delivery with heavy menstrual bleeding with dysmenorrhea. मी तिला हिस्टेक्टमीसाठी काउन्सिल केलं होतं. शी इज कम बाकी युट्रस विथ फीचर सजेस्टिव्ह ऑफ अडिनोमायसिस. आणि अजून एक पेशंट ऍडमिट झालीये.
Can you please
menstrual bleeding.
Can you please mute yourself, whoever is talking, because we are getting disturbed. So Deepakshi, our next question to you is, what is the glycemic targets which you would like to achieve when you have either given MNT or you have given insulin? So what does ADA say and what does DIPSI say? How much should be fasting and how much should be after 2 hours, or what ADA says? Yeah.
The fasting levels should be less than equal to 95 mg per deciliter. The 1 hour value should be less than 140 and the 2 hour value should be less than 120.
Correct.
And if these are not there, then we will either go for oral hypoglycemics or insulin, depending upon the blood sugar levels.
And what does DIPSI say? They only talk about fasting and 2 hours. So what should be the target when you have started treating the women? Less than 90 and 120, less than 120, or equal to whatever.
Yes.
So these are the targets by DIPSI. Fine. So now let's say that she did not respond to your MNT and you have to give insulin therapy. So if you have to give insulin therapy, what are the 2 ways of giving it?
Ma'am, if we have to give insulin therapy, then based on the total insulin requirement, we will divide the doses.
No, first tell me, what are the 2 ways? How do you give it? One is you give by multiple daily injections. And the second is that you have a very interesting pumps now, which is continuous
pumps.
Yeah, continuous subcutaneous insulin infusions. So these are 2 ways by which we are doing it. But as these CSII are very expensive, we really still go for multiple daily injections. Now you tell us, how do you give it?
Ma'am, we calculate the total insulin required for the patient in a day, and then we divide it into 2 doses. The morning dose is 2/3 of the dose is given in the morning, and 1/3 of the dose is given at night. And in the morning dose, we have to take 2/3 of the NPH insulin and 1/3 of the short acting insulin. And in the night dose, we have to take half of the NPH insulin and half of the short acting insulin.
That is the recommendation. That is the recommendation accepted universally. Okay.
Yes.
We would also like to know what are the various kind of insulins which are there, and are we really using, is there any study of using long-acting insulins nowadays?
Ma'am, the various type of insulins that are available are the rapid-acting insulins, which include insulin Lispro and insulin Aspart. Then we have the short-acting regular insulin. Then we have intermediate-acting insulin, which is the NPH insulin. And the long-acting insulins are the insulin glargine and the insulin detamil. But if we go according to the studies, we do not usually recommend use of long-acting insulins because they have mitogenic effects on the fetus, which can lead to macrosomia, which can further increase macrosomia in the baby.
Correct. Dr. Anga, we can ask the insulin requirements per week as per the weeks.
Pardon, madam?
Yeah, Dr. Anga, go ahead, please.
After insulin therapy, when do you plan delivery of this patient? Patient is on insulin, patient is under your care, you are monitoring her. What should be the plan for her delivery?
Ma'am, according to the Government of India guidelines, if the patient is well controlled on insulin therapy, we should plan her delivery after 39 weeks of gestation, after 38 weeks of gestation. And if she is well controlled on MNT, we can wait for the spontaneous delivery till 10 weeks.
So you cannot give one statement, something like this, that only this particular gestation we can deliver. See, whenever you are treating a woman with insulin, especially gestational diabetic mellitus lady, you have to be very careful because it is the later part of pregnancy where there's very high risk of having intrauterine death. So although we cannot mention this, but remember that diabetes mellitus is known to have a premature baby, even if you deliver the baby at 37 weeks. The reason being that the excess of sugar reduces the secretion of pulmonary surfactants from the pneumocytes. So it acts as an anti-secretions of the pulmonary surfactant. So what kind of maturity in preeclampsia you will have at 37 weeks, because the baby is chronically hypoxic, the blood vessels are constricted and the hypoxia is there, which becomes a factor for secreting pulmonary surfactants. So they are mature. But as far as GDM is concerned, the baby is not mature at 37 weeks. So you try to take the pregnancy to a level where you can get a mature baby. So you try to push it till 39 completed weeks. But those periods are very critical. Those few weeks are very, very critical, where you have to really monitor the patient for especially the monitoring of the baby. The fetal monitoring is extremely important. One more thing we had left, which we would like everybody to know, is that there have been if you look into your textbooks, which are a reference textbook, what is the insulin requirement, human insulin requirement as per week? So what is at 6 to 18 weeks? What is at 18 to 25 weeks? What is at 26 to 36 and 36 to 41? And the one who has massive obesity. So they have given that 6 to 18 weeks, it is 0.7, 18 to 25, 0.8, 26 to 36, 0.9, 36 to 41, 1, and massive obesity 1.5 to 2. So this is an approximation of unit per kg. And also they have calculated titration technique, which is there, where they say that 1 unit of insulin probably takes care of maximum 6 to 8 mg% of glucose. So accordingly, you should titrate and ensure that you give the right dose and do not cause hypoglycemia. Yes, Dr. Anika?
What should be the fetal surveillance methods in
anti-diabetics?
What will be the fetal surveillance method in the last trimester if you want to prolong pregnancy from 30 after 35 weeks?
Ma'am, we should the patient to have a strict
You going in and out again.
Hello.
Am I
Hello,
audible?
Dipakshi. Hello, Dipakshi.
Dipakshi, only
Yes,
4 or 5 questions more and then we will stop troubling you, huh?
Am I audible?
Yeah,
Yes,
you
yes.
are.
Yes, please, better. Continue.
We will explain the patient about
Your voice is vibrating.
we especially fetal count do 4 weeks.
We ask the patient to keep daily fetal kick counts, and you do ultrasonography bi-weekly to know for her baby's biophysical profile. The kick counts, a good biophysical profile screening ensures you that this baby is doing well in during her vasculopathy also. So you can prolong the pregnancy more. So monitor these pregnancies by biophysical profiles, NSTs, what do you have in your wards, and daily fetal kick counts. If she has any retinopathy or any hypertensive crisis, be sure that these patients get matured early, get delivered this patient earlier. Don't wait for 38, 39 weeks because they will land up into sudden intrauterine deaths. Okay.
A few more questions. One is, what is the role of oral anti-diabetic agents and where they have been recommended? Which are the two which are have been recommended in your reference books? And which are those cases where you actually recommend oral antibiotics or oral anti-diabetics?
Mama,
so as we are not able to hear you, traditionally, if you ask, oral antibiotics are really contraindicated. But then there is mixed study, which says that the women with PCOS, there, if you are continuing metformin, you can continue metformin. If you go into your certain books, they say that glibenclamide, which is unlike other sulfonylureas, doesn't cross placental barrier. So there's a study of Langer et al. They say that probably glibenclamide can be given along with insulin, but yet, we go for insulin therapy the moment we think that she is diabetes. And there are certain new things coming up, which we must know as postgraduate. However, they have not yet been proved. There's something called acarbose, which is nothing but alpha glucosidase inhibitor. They have shown in some patients that if they are given, but we do not have evidence because it's very small cases where we have done this study, but yet this is also being studied in a big way. So these are a few things which we would like to add. And whenever you are monitoring the glucose, so there's something called self-monitoring of blood glucose in diabetes mellitus, which is done 6 times a day. That has been mentioned in the reference book. Of course, your glycosylated hemoglobin is there. Then there's something which has come up in a very big way is fructosamine in pregnancy, but it is very, very expensive. However, it is very ideal index for monitoring this thing. And then latest studies say that fetal abdominal circumference, this in sonography, if you see, this is one of the very interesting parameter that your baby is going beyond your control. So that is something which is very important. So I think, Dr. Anika, if you have something more to say, because Dr. Sharmila has to go for another this thing, so she would like to have her presentation.
Little bit about the post-delivery management.
Yes.
Don't forget to follow this patient up after their delivery. COG recommendations are there. They give an idea that you have to do blood glucose levels of these patients at 6 to 12 weeks postpartum to know whether the glucose intolerance is still persisting or not. Some of these patients can continue as diabetes patients in their future life. So be assured that she is treated well even after delivery.
Dr. Deepashri, we first of all thank you for a wonderful presentation. You have mostly covered all the point and answered our questions. So as both of us as examiner, we give you A+.
Yeah.
And also we have a presentation. Please send your email ID or a WhatsApp number so that we can send you that presentation where it covers everything, because we have left a lot of part of obstetric management. So we will send you the presentation so that you can see and complete this topic. Thank you very much.
Thank you. Thank you, madam.
Thank you, ma'am.
Thank you.
Yeah, it was really wonderful discussion.
Thank you. Thank you, Sushma, madam.
Thank you, society, for giving us this opportunity. Thank you so much.
Excellent examiners.
Thank you.
But we also learned a lot. Really, it was a wonderful discussion.
We can go for Dr. Charmila's presentation. Thank you.
Deepak, she also presented well, answered well.
Thank you, ma'am.
Yeah, we can
We
go
can't
ahead.
hear what Prachi is saying.
Prachi?
Should I start?
Yes.
Introducing the madam. A very good evening to everyone. After listening a very fruitful discussion, now we are moving forward for our second session, that is the Pearl of Wisdom. And I feel profound privilege to introduce our today's speaker, Dr. Sharmila Ayavu, ma'am. Madam is a very prominent personality in the society, and she has a very magnificent CV. She is the Vice President-elect Foxy 2024. She was the chairperson Clinical Research Committee Foxy for the year 2016 to 18. She is the ICOG Governing Council member for the year 21 to 23. Madam is the National Coordinator UNICEF Foxy PCA, and she is also associated with the various PG program, PG Educational Program, Medha Foxy PG Program, Isar Gurukul Program for the year 22 to 23. Madam is the series convener for the ICOG Journal Club and the ICOG certificate courses for the year 22 to 23. Madam is WHO South East Asia Region MDSR India member. She was the past secretary Trichy OBGY Society. She is the president Menstrual Hygiene Management Consortium, and she is the secretary for the Gestational India Association and secretary academic wing of Assisted Reproduction Trichy. With this, I welcome Madam to speak on the management of GDM. Over to you, ma'am.
Thank you. Thank you so much.
1 minute. Also welcome the chairpersons. Dr. Nikita Vijay, she's chairing the session. She's a very good academician from Lata Mangeshkar.
Thank you,
And Dr. Fidvi sir is there?
No, ma'am. Ma'am, can you hear me now? Hello?
Yeah. Yes.
Okay, I'm
Please
sorry. I
introduce,
think
Dr.
the time.
Nikita.
Yeah, I'm sorry. When I was introducing ma'am, I think I was not audible for some reason. I was
No, no
thanking
problem.
both of the teachers, Poonam ma'am and Anika ma'am, for giving their precious time. And I'm sorry. I welcome our prestigious next chairperson, Dr. Nikita ma'am. She is Associate Professor in Ankiti Salve Institute of Medical Sciences, and she is a very devoted teacher to students and very good in research and awarded researcher. Ma'am, I would like you to take the session forward. You've already done your job, but it's still a kind welcome.
Over to you, Madam Chirai.
Yeah,
Thank you so much,
Yeah.
Dr. Nikita and Dr. Prachi. Thank you so much. I'm sorry that I interrupted such a great session, but it's a FIGO program and we're supposed to join by 8:30. But I think it will take more time, but it is always an honor to be in a program where Dr. Poonam ma'am is there. And Dr. Anaga seems to be from Grand Medical College, and I'm also a student of Grand Medical College, Bombay. It was an honor to listen to both of them when they're talking so well. And the student did so well. She was talking about insulins so clearly. Such clear clarity of thought in a PG is always welcome to listen to, because we think that they don't understand, but they are much more better than what we are doing at this age. When you want to classify anything, any hyperglycemia in pregnancy, it can be diabetes in pregnancy or gestational diabetes. It's so simple. There's no confusion at all there. And that is it depends on the WHO diagnostic criteria and classification of hyperglycemia. It is first detected in pregnancy. And what you call as GDM is, this definition is there from the American College. It is defined as carbohydrate intolerance of variable severity with onset or first recognition during pregnancy. That is GDM. When it's diagnosed earlier, it is never GDM. You have to diagnose it only during pregnancy. And the FIGO guidance for the diagnosis is hyperglycemia, as I said, can be diabetes or gestational diabetes. Diabetes in pregnancy is again classified as diagnosed before the start of pregnancy and diagnosed for the first time during pregnancy. And when it's diagnosed before the start of pregnancy, it can be type 1 or type 2. And when it's diagnosed for the first time during pregnancy, then also it's classified as type 1 or type 2, depending on the dependence on insulin for therapy. What is the difference between diabetes and GDM? A lady who is pregnant and is already a diabetic, or hypoglycemia is diagnosed for the first time, but she meets a WHO criteria for diabetes mellitus in the non-pregnant state. That is, she's got a very, very high sugar value when she's diagnosed in the first time during pregnancy. Diabetes in pregnancy can occur at any time during pregnancy, which includes a first trimester. But when you want to diagnose gestational diabetes, hyperglycemia during pregnancy, that is not diabetes. That is the criteria for a full-blown diabetes should not be there when you want to say it's GDM. It should be diagnosed for the first time during pregnancy. It can occur any time during pregnancy, but it's most likely after 24 weeks when the placenta throws up its hormones and it causes a diabetogenic effect on the mother. So WHO 2019 has come out with this classification. Diabetes mellitus in pregnancy, as I said, type 1 or type 2. And GDM is, and it's below the diagnostic thresholds for diabetes in pregnancy. That is, when you have a fasting sugar which is more than 126, she straight away becomes a diabetic. She's not a GDM. And when her 2-hour post-load plasma glucose is more than 200, when there's a very high fasting or 2-hour post-load, then also she becomes a diabetic in pregnancy. And when the HbA1c the first trimester is more than 6.5, she's classified as diabetic in pregnancy. So the controversies in diagnosis of the disease is there. Like, why do you want to screen every pregnant woman, which has been advocated by the government of India? How will you screen all the ladies for GDM? Should it be universal or selective, or should it be done in the first or second trimester? You have to remember that you should do it as a universal screening, because the short-term complications of the disease can be in the mother and the fetus. The mother can land up with preeclampsia, polyhydramnias, prolonged labor, obstructed labor, cesarean section. There is more incidence of PPH and there's more incidence of infection. Fetal will be spontaneous abortions, intrauterine deaths, stillbirths, congenital malformation, shoulder dystocia, birth injuries, neonatal hypoglycemia, and RDS. Long-term complications, as Poonam Madam was saying, it can be almost like 50% mothers will develop type 2 diabetes in the next 20 years. And the fetal effects are quite long lasting. The baby is going to be obese as an adult and is going to be diabetic at a very, very young age. The mother has had GDM. And the burden in India is almost like 10 to 14.3%. That was a long back. Now, I think it's crossed 25%. In America, it's 5 to 6%. And there also it's crossed the limit of 20 to 25%. So how do you screen? According to the Indian guidelines, the protocol is universal testing. Every lady who walks into your antenatal OP should be checked for GDM. Testing for GDM should be done twice in pregnancy. First is at the first antenatal visit. Second at 24 to 28 weeks, the first is negative. And suppose she's come only beyond 28 weeks of pregnancy, you will check at least once. How do you do the test? This I think everybody knows. Single step in India. 75 grams glucose mixed in 300 ml of water. She can come in the fasting and non-fasting state. The intake has to be completed within 5 to 10 minutes. A standardized glucometer should be used to evaluate the blood sugar 2 hours after the oral glucose load. Suppose she vomits within half an hour of the intake, the test can be repeated the next day, or else she should be referred to another facility. If the vomiting occurs after half an hour, the test can be continued. The threshold of more than or equal to 140 milligram per DL is taken as a cutoff for diagnosis of GDM. So according to the government of India, the management of GDM is the first instance you will put her on medical nutrition therapy and physical exercise for 2 weeks. And non-pharmacological treatment, which is nutrition therapy and exercise, is the cornerstone of treatment of GDM. It's not only drugs, it has to be nutrition therapy and exercise, because exercise will decrease the peripheral insulin resistance, which is the main pathology of GDM. And it will always form as an appropriate adjunctive therapy to diet for the GDM patient. And patients are encouraged to participate in at least an exercise activity for half an hour, several times in a week. And how do you calculate for MNT the energy requirement? Suppose she is a person who is doing sedentary work. The energy requirement during pregnancy is 1,900 plus 350 calories. And suppose she's doing moderate work, it should be around 2,230 plus 350, that goes on to 2,580. Suppose she's a person who works hard, 3,200 calories should be given. Suppose she is underweight, you have to give additional 500 calories. And suppose she's obese, you should reduce 500 calories per day, calculated for the nutrition therapy. And the pre-pregnancy body weight is always taken into consideration when calculating the requirement. It's not the pregnancy body weight, it should be the pre-pregnancy body weight. And as per ICMR guidelines, for an average weight gain of 10 to 12 kg, the lady should be given an additional 350 kilocalories per day above the adult requirement in the second and third trimester. So how do you calculate the meals? You have to spread the carbs over 3 small meals and 2 to 3 snacks each day. rather than taking 3 large meals. It should be all complex carbohydrates in the form of whole grain cereals, whole pulses, vegetables, and fruits with the skins intact. And they should be preferred over the simple carbohydrates like the baked foods and foods which have added sugar or honey, or it's made from refined white flour. And the aim should be 2 to 3 carbohydrate serves at each major meal and 1 to 2 carbohydrate serves at each snack. The saturated fat intake should be less than 10% of the total calories, and at least 3 servings of protein should be given to meet the increased demand during pregnancy. And according to DIPSI, their nutritional therapy is every day. Carbs, proteins, and fats should be divided in such a way. Breakfast, lunch, and dinner, 3 servings. Each should have a carbohydrate serve of 45 grams and 2 snacks of 30 grams. Protein should be 2 to 3 cups of thick dal or whole pulses per day for vegetarians. And for non-vegetarians, 2 eggs per day, preferably white only. Or they can have cooked chicken or fish 1 cup per day, which is served with 1 cup of dal. Fat should be 20 ml per day of cooking oil, which is equivalent to 4 teaspoons of cooking oil. They can use toned milk for milk or curd. And after the second trimester, they can increase it from 500 ml to 750 ml per day as milk or curd. That is the DIPSI guidelines for nutrition therapy. But the most simple one is when you give a patient a 10 inches radius plate, half of the plate, she should have cereals or whole grains or millets. Quarter should have proteins, dal, and whole pulses for vegetarians. And protein for a non-vegetarian will be egg, fish, chicken, mutton. And quarter of the plate should contain green leafy vegetables, watery vegetables, traditional vegetables, and beans variety. She can add curd 200 ml for breakfast, lunch, and dinner. The snacks in between these meals should be preferably roasted or boiled Bengal gram and sprouts for salads. And when you do a combined management, even if the patient is put on insulin, make sure that the diet plan is put in place, because that is the most important focus of gestational diabetes mellitus management. And Poonam Madam was talking on blood glucose monitoring. Is it essential when the patient is on diet alone? Yes, definitely you have to do a blood glucose monitoring, even if she's on diet alone. According to the American College, you have to do a fasting and 3 postprandial levels. Self-monitoring is much better. And once target levels are met, you can reduce the frequency of testing. But if the target levels are not met, she will be moved on to a pharmacological management. But according to the American College, you have to check her 4 times a day, even if she's on diet alone. According to the government of India, when she's on medical nutrition therapy, you need not check her blood sugar daily. You can check her blood glucose 2 hours after a meal, after 15 days. There's not even a need for a fasting levels to be tested. And suppose she maintains her postprandial levels to less than 120, she's continued on medical nutrition therapy and exercise. But suppose she is, if she's more than 120, then you need to do a high-risk pregnancy protocol for her. That is, she needs to undertake 8 tests. That is 4 regular tests and 4 additional. And it's recommended to conduct at least 1 test every month during the 2nd and 3rd trimester. This is correct, actually. That is, if it's less than 120, you need not do a monitoring like in the American College, but you should do at least additional tests until she delivers. And that should be at least 1 test for every month of a postprandial blood sugar. This is according to the government of India. But suppose you feel that she's not controlling herself well, you can actually increase the number of tests. Otherwise, for a person who's on a diet is not so cumbersome. It's like once in 15 days first, and then it is like once in a month. She's controlled quite well. And according to the other guidelines, the American Diabetic Association has given a target value of a fasting of less than 95, a 1 hour of 140, and a 2 hour value of 120. The Diabetic Association also advocates a daily monitoring with fasting and 3 postprandial levels. You will do preprandial levels only for women who are having a pre-existing diabetic status. Otherwise, for GDM, there's no need to do a preprandial level. A postprandial level along with fasting is more than enough. And then all guidelines, HbA1c is not useful for monitoring. And regarding pharmacological therapy in GDM, 25 to 50% of the women with GDM will require insulin or oral agents. And the agents which have been advocated are metformin, glyburide, and acarbose. Regarding metformin, it has been used successfully almost 40 years to treat diabetes outside of pregnancy. It is used during pregnancy as an alternative or an addition to insulin. It is a drug which will improve the insulin sensitivity, and we expect it to therefore to reduce the physiological rise in insulin resistance which happens during pregnancy. and has been quite well studied in PCOS patients when they have used it for the first 12 weeks of gestation. And it's a biguanide, and the indication according to the government of India is if a person develops GDM after 20 weeks of gestation, then it's used for the medical management. The dose is 500 milligram twice daily orally, and you can go up to 2 grams per day. But there's some advantages metformin. Hypoglycemia, weight gain are much less compared to insulin. And when you require insulin for the patient to control the sugars, metformin may be added to the treatment. And the common side effect that occurs with drug is diarrhea, nausea, stomach pain, heartburn, gas, and the serious side effects like lactic acidosis and severe hypoglycemia. Glyburide is a sulfonylurea, which is used as an alternative to insulin therapy. Its main action is by enhancing the insulin secretion. The starting dose is 2 to 2.5 milligram per day in divided doses, and you can go up to 30 milligram when necessary. Hypoglycemia can happen with glyburide also, and that is a dangerous complication sometimes. And the most common mild side effects are gastrointestinal and dermatological, which can be nausea, vomiting, dyspepsia, pruritus, urticaria, and eruptions. A-carbose is a glucosidase inhibitor. It will reduce the intestinal absorption of starch and then will reduce the rate of complex carbohydrate digestion. So it will lower the postprandial glucose levels, which is needed in the GDM patient. It has been actually used for type 2 diabetes for a very long time. Due to less than 2% absorption in the maternal circulation, these drugs may have a potential benefit in pregnancy, but there's one side effect which can have negative consequences in pregnancy, and that is there's a bacterial breakdown of the starch, and that will lead to the accumulation of butyrate, which is supposed to increase the prostaglandin E secretion, and that can cause problems during pregnancy. So at present, the use of alpha-glucosidase inhibitors is not recommended because of the lack of human pregnancy safety data. And according to different guidelines, how will you give the drugs in GDM is, according to the government of India, once GDM is diagnosed, the mother is put on a medical nutrition therapy, and it consists of meals where carbohydrate intake is controlled, as I said earlier. And there's an optimization of nutrition to meet the nutrition needs of the mother and the baby. And the plan should include energy appropriate food for optimum weight gain. At the same time, there should be maintenance of normal glucose level. And you add exercise regimes always. Regarding oral drugs, according to the Government of India guidelines, if it's the mother is more than 20 weeks of pregnancy and she's got GDM, and if it's more than 120 postprandial, then you'll give her metformin. When on metformin, you have to check her blood sugars twice in a week or sometimes even much earlier also when needed. And the advantages, according to the Government of India, is it started at 500 milligram twice daily. And it is because reduced maternal weight gain, which is supposed to be one of the best good effects of metformin. And the incidence of hypoglycemia is much lesser compared to the other drugs. And when you give insulin, according to the Government of India guidelines, if the postprandial blood sugar is not maintained at less than 120, and she's less than 20 weeks, suppose it's at earlier pregnancy, you diagnose GDM, it's better that you start an insulin if she's not getting control with diet and exercise. Because they say when you start it very late, by the time either macrosomia or hydramnios have started. And when on insulin therapy, the mother should be checked for blood sugars every third day or sometimes even frequently. Targets to be kept for fasting is 95 and postprandial should be less than 120 when she's on insulin. And suppose the blood sugar target levels are not maintained, you will add insulin. And suppose the 2-hour postprandial blood sugar is very high at the initial diagnosis. As I said, suppose it's very high, about 200, it's better that you start insulin in early pregnancy. NICE guidelines is little difficult, they're little different. That is, the diagnosis of GDM is when the fasting plasma, because they don't do a non-fasting screening for GDM. It's always with the fasting level. So with the fasting plasma glucose level is more than 100 and the 2-hour plasma glucose level is more than 140, she's diagnosed with GDM and she'll be put on diet, therapy and exercise as in Government of India guidelines. She'll be reviewed after 1 to 2 weeks. The target levels are not met. There you'll do a fasting and a postprandial again. It's not only postprandial as the Government of India advises. Here you will start oral metformin or insulin therapy depending on what are the sugar levels. Indications for insulin is it can be started at once according to NICE guidelines. There's a contraindication of the patient is not interested in oral drug therapy. And when the target levels are not maintained at metformin, you need to add insulin. Immediate initiation of insulin therapy according to NICE guidelines is the fasting level is more than 126 at diagnosis or If it's between 100 to 125, but this macrosomia hydramnios, it's better that you start insulin. And glyburide is initiated when there's an intolerance to metformin, or the patient refuses insulin therapy and is not controlled on metformin. Then the third line will be glyburide. The American colleges, once a diagnosis of GDM is made, patient is put on nutrition therapy. Target levels not achieved, she'll be put on straight away on insulin. Glyburide and metformin has now been recently added to the therapy regime, but they are not a big advocate of oral drugs for management of even GDM. And when you want to compare metformin and glyburide, they found that metformin required additional insulin compared to glyburide. That was a study in 2010. And when comparing the two oral agents, metformin is much safer than glyburide because glyburide is associated with more of neonatal hypoglycemia and higher birth weight. It can increase the risk of shoulder dystonia and the need for a cesarean delivery. Metformin will have a lower risk of neonatal hypoglycemia. So it's much safer compared when you think about the fetus. And when you want to compare oral drugs with insulin, even though there are no clear guidance, the American Diabetic Association recommends to consider metformin and glyburide for the treatment of GDM. But there are concerns regarding the long-term safety according to ADA because they cross the placenta. ADA and NICE guidelines do not report any restriction on the type of insulin for use in pregnancy, while NICE prefers the use of NPH, intermediate-acting insulins, as a first choice instead of long-acting. And aspart and lispro is preferred for rapid-acting insulin action. It's not the older drugs, atrapid. It's aspart and lispro. How do you monitor when the mother is on drugs? According to American College and NICE, it has to be daily. It's not every third day as the Government of India guidelines is putting it. And when you want to monitor according to the Government of India guidelines, every third day, both for insulin and metformin, target levels has already been mentioned. And you start on insulin therapy when it's not controlled. And the insulins you prefer is regular and NPH insulin, the short-acting insulin analogs, that is lispro and aspart, all are considered safe for use in GDM patients. Indications is insulin at any time if she's got a diagnosed GDM before 20 weeks. And suppose she's after 20 weeks and MNT is failed, then also insulin is started. And if the initial diagnosis is initial levels of diagnosis more than 200, it's better that you start insulin than instead of going for metformin and other forms. But the disadvantages of insulin therapy in GDM is great. It's quite imperfect because the mother needs lots of education because she's not have any symptoms at all. And she's not used to being called as a diabetic. So you need to educate her a lot. Hypoglycemia and weight gain is very common with insulin therapy in GDM patients. Then there's a limited acceptance and there's a high cost involved. And there is a psychosocial deprivation associated with GDM when the mother is put on insulin. And that's why all the guidelines are asking us to try out with oral drugs like glyburide and metformin before moving on to insulin. And American College, the dose they advise is 0.7 units per kilogram body weight. And you have to calculate the total daily dose, and 2/3 will be administered before breakfast and 1/3 in the night. The morning dose should have 2/3 of NPH and 1/3 regular insulin. The remaining 1/3 is broken up into two different doses, and that is half will be regular and half will be NPH. The regular insulin should be given before dinner, and the NPH insulin should be given at bedtime for the morning levels. But there are some alternative regimes for GDM. You need not give such high doses of 0.7 milligram per kilogram per body weight because that can cause hypoglycemia in a big group of patients. And there's a regime by Dr. Stephen Gabe where he says you just start with 15 to 20 units of NPH in the morning and at bedtime with the fasting glucose, and you add a bedtime dose with the fasting glucose is elevated. And you add 5 to 10 units of rapid-acting insulin to cover the specific mealtime elevations of lunch and the other meals. But starting at 15 to 20 units is more than enough according to them. And suppose the fasting is high, then you give a bedtime dose. Dr. Pai has brought out a regime after a study in Manipal. There, sir says, for the initial control, short-acting insulin, 444 is given, and you monitor her blood sugar levels. If the target levels are obtained at a particular dose, then you make the same calculation as an NPH of 2 doses. So she need not be taken 3 doses a day, and that he says covers very well. And suppose she's having fasting hypoglycemia, then it's better instead of short-acting insulin, that is NPH should be added definitely at bedtime to control the morning sugars. The Government of India guidelines is very simple regarding management with insulin. It is always a pre-mix of 30:70. And if our blood sugars is between 120 to 160, you give 4 units in the morning. If it's between 160 to 200, you start at 6 units. With more than 200, you start at 8 units of insulin. And you monitor with fasting and 2-hour postprandial every third day, and you know the target levels. And suppose a fasting blood sugar is controlled, but the 2-hour postprandial is high, then you will increase the insulin in the morning by 2 units. You will add MNT and physical exercise. But suppose with the insulin you are giving, if both her fasting and 2-hour postprandial are high, then you will add insulin in 2 doses. That is, you add 2 units pre-breakfast and 4 units pre-dinner. You have to start now. If the postprandial alone is elevated, a pre-breakfast 2 units addition is needed. Fasting is elevated, a 2 units pre-dinner is needed. It's very simple according to the Government of India guidelines. So we want to summarize the management according to the American College and NICE. Target levels 95 for most of them, 96 for NICE. 1 hour is 140 and 2 hour is 120. But for NICE guidelines, it's 1 hour it's 140 and 2 hours is 116. Not controlled with medical nutrition therapy, insulin is the first choice. According to the American College, NICE guidelines says you can try metformin. And if in 2 weeks there's no control, you'll switch over to insulin according to NICE guidelines. Daily monitoring for all the GDM patients according to both the guidelines. Metformin, if she declines insulin according to the American College, but it will be glibenclamide according to NICE if she refuses insulin and she's not controlled with metformin. The fasting is more than 126, straight away you'll start her on insulin according to the NICE guidelines. And there's one additional feature for metformin according to American College. You will check a baseline creatinine level before starting metformin. So the guidelines, the difference is there. First line therapy, Indian, NICE, American College, and the American Diabetic Association is always medical nutrition therapy for GDM. Second line therapy will be metformin for India. NICE guidelines can be metformin, insulin or glyburide. American College first choice is insulin. If she refuses, it will be glyburide or metformin. American Association also the same. Third line therapy in all guidelines is always insulin. How will you deliver a mother with GDM? Government of India guidelines is if she's well controlled, you will do an induction of labor at around 39 weeks. But if she's having a poor blood sugar control, and suppose she's having an additional risk factor of hypertensive disorders in pregnancy, has suffered a previous stillbirth, has had other obstetric complications, you can deliver her early if she's on a poor blood sugar control. But you can time the delivery by an individual basis. And the vaginal deliveries should be preferred and cesarean only for an obstetric indication. And if there's a fetal macrosomia with estimated fetal weight is more than 4 kg, you can consider a primary cesarean section at 39 weeks to avoid shoulder dystocia according to the Government of India. NICE guidelines, suppose she is a gestational diabetic, she can be continued till 39 plus 6 weeks. 39 plus 6, that's almost term. And offer an elective birth, which can be induction or cesarean section, who have not given birth by that time. And suppose she's got with the maternal or fetal complications, you will consider delivering her even before 39 weeks plus 6 days. And you have to explain to a lady with diabetes and she's got a macrosomic fetus. You have to tell her the risks and benefits of vaginal birth, induction of labor, and cesarean section. American College, control on diet, go on up to 39 weeks. Expectant management can be done for these ladies even up to 41 weeks with appropriate antepartum testing. And she's supposed on medications, not control on diet alone. It's better to deliver at 39 weeks to 39 weeks, 6 days. Poorly controlled, 37 to 39 weeks. And delivery between 34 to 37 weeks should be reserved for failure of even in-hospital glycemic control or there's an abnormal fetal testing. If the estimated fetal weight is more than 4.5 kg, you will counsel her regarding the risks and benefits of a scheduled cesarean section. Management of labor. Suppose she's on insulin and she's gone into labor. For a person who's on diet or metformin, there's not much of management during labor. It will be done as like any other patient. But suppose she's on insulin, you will give her the usual dose of intermediate acting insulin at bedtime. Morning dose should be withheld. You should have to start an IV infusion of normal saline. And once active labor starts, every hour you have to check her sugars. If it decreases to 70 milligram per DL, the infusion should be switched over from saline to 5% dextrose and should be delivered at a rate of 100 to 150 ml per hour. You can give 2.5 ml per minute per kilogram to achieve a glucose level of 100 milligram. And glucose, as I said, should be checked every hour. And regular insulin is administered by intravenous route at a rate of 1.25 units per hour if the blood glucose exceeds 100 milligram per dl. And regarding HbA1c, it can be done only at the booking appointment, and that too specifically for ladies who are having pre-existing diabetes to determine the level of risk during the pregnancy. In the second and third trimester, so you can do it in pre-existing diabetic mothers, but it's not useful for GDM at all. And be aware that there's a high level of risk for women who got HbA1c above 6.5. And you should do in the first trimester if you're diagnosing diabetes for the first time, as in a GDM, to identify whether she's actually a pre-existing type 2 diabetes who has been missed in the preconceptional period. Do not routinely use HbA1c levels to assess the lady's glucose control in the second and third trimesters of pregnancy. The objective should be a good diabetic control, and antepartum fetal surveillance should be on point, delivery at the appropriate time with an optimal neonatal support. And self-blood glucose monitoring is very important, as Madam was saying. Medical nutrition therapy and insulin therapy should be started appropriately when the target levels are not met. And oral hypoglycemic drugs to be considered if the mother refuses insulin and is non-compliant. So the summary will be, the Government of India says GDM diagnosed, MNT and exercise. After 15 days to check the postprandial blood sugar, less than 120, continue on MNT and exercise, not maintained at less than 120, and she's still less than 20 weeks of pregnancy. Insulin therapy is ideal. When on insulin, monitor sugars every third day or more frequently. If she's more than 20 weeks and a postprandial has come as more than 120, we'll put her on metformin, which has failed medical nutrition therapy. Even when she's on metformin, blood sugars should be tested twice in a week. If the blood sugar target levels are not obtained with metformin, insulin should be added. And insulin therapy is the best therapy for glycemic controls, even in patients with GDM, but it's an expensive drug and will need lots of motivation for the patient. Then oral drugs like glyburide and metformin can be tried. But oral drugs are not meeting the target, then you'll add additional insulin. Plus, metformin should be used with caution. It should not be used as you're doing indiscriminately, because it can cross the placenta, and we do not know what it's causing in the baby, and the long-term effects are not known at this point of time. Glyburide is always the higher chance of neonatal hypoglycemia. Both the drugs are less effective with the fasting sugars, a very higher diagnosis. Or GDM is diagnosed before 26 weeks of pregnancy, then probably should consider starting insulin much earlier instead of going for the other forms of therapy before switching to insulin. This is the algorithm for that. And these are references. Thank you so much, Dr. Sushma, Dr. Pragati, Dr. Prachi, and Dr. Society. Thank you so much.
It was amazing, wonderful, Dr. Charmila. Really, it was very practical points. Yeah, chairperson to say.
Thank you so much, Madam, for giving the wonderful insights into the management of the GDM. Madam has very beautifully explained all the guidelines, whether it's a Government of India guideline or it's a NICE guideline or a SCOG guideline. Whatever is the guideline, the first line management is MNT, 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 and exercise. And then the second line management can be insulin or the oral hypoglycemic drugs. Thank you so much, Ma'am.
Thank you. Can I leave?
Thank you so much,
Thank you very
Charmila,
much. It was really, thank you. Thank you, Dr.
for covering
Charmila,
all
really.
of the management of GDM so concisely and explaining all the rationales. Thank you so much, ma'am. Poonam ma'am, for being with us for whole of the time. Thank you, Nikita ma'am, for chairing the session very nicely. Dipakshi being there, listening to the lessons, and I'm sure she's got a lot of it. Yeah.
Yes,
Thank you so much, everyone. Thank you so much, Sushma ma'am, for this wonderful platform.
Yeah, it
Thank
was
you,
very
ma'am.
wonderful.
Bye-bye.
Hello, you call off the meeting here. Okay, thank you.